and detention. She was awarded the Medal in the Order of Australia for her work with asylum seekers and maltreated children. Welcome, Louise, and we look forward to what you've got to say. Thank you.
Thanks very much, Carol. Can I have the first slide, please? Thanks. So I thought a good way, hopefully, of introducing such a broad area of topics would really be to give a bit of an overview of some of the impacts that we've all experienced in different ways from the pandemic and what maybe it can tell us about both our current circumstances and vulnerabilities, but also thinking towards the future. So how do we actually apply concepts of recovery, resilient and supporting crucial relationships, particularly for infants, children and adolescents in the pandemic world? Next slide, thanks. So obviously, as we're all experiencing with some of the debates circulating around at the moment, the pandemic has been, on the one hand, a great leveller. No one, when all this started, was immune to the effects of the virus. It was seen as a great opportunity for bringing people together as we collectively, as humans, faced this challenge. In reality, we've seen a tremendous, if you like, fragmentation, different points of views, complex arguments, and increasing sense that some people have been very much left behind in the entire approach that we've taken to this. There are some who are more vulnerable than others. And what I'm wanting to say is something about how we should maybe think differently about the vulnerable and how better to support them. And then moving on to think about mental health issues and how a mental health system might be able to work in a more equitable way. So the challenges as I see them are also both opportunities if we do want to bring about broader-based social change. We had, as I said, the opportunity for a collective or more cohesive approach where we attempted, at least at the beginning, to reach out to those who were defined as vulnerable. I think there are problems in the way that that's been done. The alternative, and maybe in some parts of the country we're looking at that, are increasing social divisions and social fragmentation. So there are some areas, some groups, and particularly vulnerable groups who are identified as so-called high risk, which might be true in a very concrete sense, but really serves to strengthen boundaries between people rather than bring people together, and a lack of what I see as an appropriate reaching out to people. We have ideals about social equality, and what we're seeing in many parts of the country, practices and policies that embed inequity, which is felt very clearly by those communities and groups that are impacted by this. And one of the other major issues that we're currently thinking about is the crisis of values that we're facing. The debate has become increasingly polarised, with those who value and argue more from a public health and health perspective and about mental well-being, as opposed to those who appear to be much more clearly focused on economic interests and, in the current climate, rebuilding as quickly as possible, almost without reference to possible health consequences and the impact on those who are already left behind and undervalued in the current program of response to the virus. Next, thanks. So we need to look at the forces that are circulating within communities alongside the virus, if you like, and think maybe more creatively about how we're going to actually advocate for some of the core principles of equity and access and community-based support. And these are complex issues. We are facing in some circles obvious fear of the situation. Some people are in denial, so not wanting to think about the consequences. or health implications of this virus, let alone the impact on the hospital system. There are some, as we know, disbelievers and conspiracy theorists, and some of those theories are, of course, very difficult to understand. They have complex origins in particular political views from the far right. And at my own workplace the other day, having survived the Melbourne earthquake, we had groups of protesters being chased by police outside the front door, which brought it very much to home. So these are very real, if minority group views, but they create unease and unrest in a lot of people, and their connections in a global sense are also very concerning. We're seeing in many communities and also reflected in some government policies, which is concerning, discrimination on the basis of several things, but discrimination on the basis of age and disability, gender, ethnicity, and social area, so area of living, but also class. And I think that's part of the discussion that's very important for us all to have and think through. The utilitarian argument advanced by some of the economic theorists would really argue that we should be looking at prioritising those who will give us greater quality life years on the basis of economic productivity, which in a sense means that if you're someone who's very elderly, not working, using health services, then your life does not count in an economic valuation sense as much as a young person. This is, in a way, is a very simplistic but also very divisive argument when really lives matter in different ways. So I think that's highly contentious. We are seeing specific issues affecting particular ethnic groups. We're seeing significant deficits in responding to the needs of those groups and Indigenous communities. And this has major health consequences in the immediate sense, but also is very undermining to any notion that more parts of the community would like to think Australia is doing well, which is debatable, in terms of actually addressing issues of racism and alienation for very vulnerable groups. There are also, as I'll discuss shortly, very gender-specific issues that have also not figured into the current approaches. Now, of course, we've had limited time to create some of the policies, but it has been, I think, very confronting to see, particularly in the multicultural areas, the actual identification of ethnicity per se as a risk factor for the virus, and that people's living arrangements, in other words, their transgenerational and communal lifestyles are to blame and should be changed. Similar arguments have been raised with Indigenous communities, and that's really created a major challenge in terms of actually controlling the virus and providing anything like adequate care. So the virus has major impact on marginalised groups in our community, particularly the socially excluded, women, as I mentioned, certain groups defined on the basis of ethnicity or race, and homeless populations. And with the move to opening up, as we're hearing discussed very much at the moment, the health or emotional well-being of these groups is barely mentioned in a specific way. In fact, the homeless, at least in Victoria, are facing eviction back onto the streets, and there's no provision currently for ongoing emergency care or linking people who often have comorbid mental health problems back into a service network that can adequately meet their needs. And it's not as if we haven't had a lead-in or a period of time when this could have been maybe better addressed. The issues for those with enduring mental illness in the community are also particularly poorly addressed. We've had some limited, I can speak for Victoria, not the rest of the country, but in Victoria, some approaches to setting up innovative approaches to supporting groups who otherwise have very little in the way of social services. So Albert Road Clinic, where I work, we offered and had a COVID unit set up for people with chronic mental illness who'd been living in very substandard, overcrowded, poorly run boarding house facilities in the city. That was, great support for those few people who could use such a facility, who otherwise might have been in very dangerous circumstances. We currently are still running that unit for those who cannot tolerate various forms of quarantine on the basis of their mental illness. So in some ways, we have the opportunities to better think about the vulnerable and to support them. My argument is that we could be doing a lot more in a proactive way. Next, thanks. So in many ways, this is a crisis, as I see it, of values. How we think about equity and the value that we place on human life. It's clear that decisions have been made that some people are less valuable to others. I think the decision to delay vaccination to people with disability under the NDIS taken by the Commonwealth Government is a good example of making a decision that some were less valued than others. We've also seen the failure to address in a realistic and collaborative way the issues facing Indigenous communities, particularly those in remote areas. And we've now seen incursion of virus. And we have seen, I'll use New South Wales as an example of this, of particularly harsh policing processes and lockdown and criticism of people living in southwest and Western Sydney on the basis largely of identifying cultural values which are seen as minority values but also intrinsically dangerous values. And I think the risk is that this will obviously play in to underlying currents in our community that would very easily seek to blame marginalised groups. The other two groups who've barely received any focus at the moment would be people serving time in prison, where there are significant issues with virus and overcrowding, lack of capacity to really manage other than very severe 24-hour lockdown, which is what's happening currently, and immigration detention centres. Again, overcrowding, very opaque in terms of health policy and approaches. Next, thanks. We, of course, in mental health services, bear the frontline work in many ways of the impact of social isolation and the restrictions as they've rolled out. Victoria, of course, is the most lockdown place in the world, apparently. And what we're seeing at the moment is a bit of an epidemic of people feeling obviously lonely, isolated, anxious, coping with uncertainty, coping with varied access to information about what's actually going on, people losing motivation, becoming fatigued, some developing depression. This is particularly evident amongst children and adolescents who are particularly vulnerable, I would think. There are some who've used it, interestingly, maybe in a more, if they're lucky enough, people to have good community supports, family groups who are functional, and have actually come up with very positive ways of trying to use the isolation, at least in the short term, in a positive sense. But the issues the systems are facing are to do with substance use, particularly alcohol, because alcohol can be home delivered 24 hours a day, even in lockdown. And in Victoria, we have an ongoing curfew, but the drink can still be delivered. And there are obvious issues with increasing family conflict and particularly domestic violence, with virtually a 50% increase in calls to emergency support, which is actually very difficult to deliver. A, because of lack of services, but B, lack of capacity for largely women who are experiencing these issues to actually leave where they are with their children. Next, thanks. But there is resilience in the face of this, and I think one of the tasks, particularly for those working in mental health, is to think about how do we build resilience in the face of isolation. The things that have helped, often limited, but local and community initiatives and areas themselves who have taken up the opportunity to try and support others. That's clearly given them a focus, but has also supported some of the very needy, such as isolated elderly who might be living alone and so on, or people with very young children who are also isolated. In a psychological sense, one of the positive aspects has been a process of rethinking and reflection on what core values do we actually want. And I put this as the bigger challenge that we could really work on these issues, and people are doing it individually and within their social groups, of thinking about what long-term changes we want to social organisation. Work and employment is obviously one example where many people are not valuing some greater time for families and relationships, as opposed to saying that they will keep up the long commute into the city, the working in the office, and working 5 or 6 days a week. Now, that's an economic issue, but it's also beholden, I think, on workplaces as well, to be able to have some discussion with people about how society could be better organised. That creates more time for relationships, but also more time to contribute to social growth and social organisation. And one patient that I worked at described to me a process that she said was meditation on simplicity. In other words, what she was able to do, obviously a resilient person, was to take some comfort and psychological growth in rethinking core issues and focusing on some of the very simple pleasures that could still be enjoyed if you're lucky enough to have safe housing and hopefully a bit of an outdoor area, which she actually was. But of course, that's not actually available to all people in Victoria. We've seen some really very concerning responses to people living in the high-rise public housing who are often of asylum seeker and refugee background, with very limited resources, who faced immediate lockdown with very limited notice of that, and didn't even have much in the way of community-based language information. So very concerning. So I'll end just by saying a few words about some of the key issues for mental health services. Some I've mentioned, but just to add that mental health services obviously are struggling at the moment to provide care. That is an ongoing issue. In order, though, for people to continue to provide care, we need to think about what the actual system needs, both in flexibility and bringing in more innovative programs, be that working with technology and so on, or more outreach type of mental health programs, but also what the workforce needs to be able to manage and think through some of these issues. All of us are affected by the virus and the impacts it's had on our lives. We have responsibilities to self-reflect, to self-care as much as possible, but also to think about the systemic response to the whole system and how we're actually going to care for the people that we need to care. Thanks very much.
Thank you, Louise. As I would expect, your insight, humanity, compassion shows through, but of course is backed by evidence, research, enormous clinical knowledge, and a capacity to cut to the core of the challenges we're facing at the moment. you've left much for us to think about. I do like this notion of perhaps building resilience through working, each of us individually, on learning how to live simply. It's got a lot to commend it. Thank you again, Louise.
Thank you, Bruce.
For your time and contribution. We move now to our next speaker, who I'm delighted to introduce, a colleague of mine, a leading light and inspiration to child and adolescent psychiatry across the country, and that's Helen Milroy. Helen is a Paliku woman from the Pilbara region, who is also a graduate medical practitioner and leading child and adolescent psychiatrist, both in the academic and clinical sphere, and in terms of informing across the nation around healthcare policy for children and families in general, relevant to all the nation, but in particular for that part of our community that we've all acknowledged today is marginalised, forgotten, and that's our Indigenous community, and even at the moment forgotten in terms of an equitable rollout of vaccination. So Helen, thank you for coming to talk with us today, and I look forward to your address around the family, social, cultural and political issues facing families in the context of the environment of a pandemic.
Thank you, Bruce, and thank you everyone for joining us today on this really important day focusing on mental health of our communities, but also in my particular passion, the mental health of children. Just going to quickly share my screen so I can bring my slides up. It's always good when technology works. I always get great encouragement when it all goes to plan. So look, a bit like Louise, I've probably prepared too many slides, so we'll see how many we get through, and the rest can be shared if needed. I've really enjoyed the previous speakers, and I think that the first comment, well, actually, before I really get started, I'll just acknowledge the traditional owners and all the lands on which we meet today, and I'm incredibly lucky to be on Whadjuk Noongar Budja here in Perth in Western Australia, and pay my respects to elders past, present and emerging. Just in terms of the speakers that have gone before me, I think they've raised a number of really important issues. And just to make the sort of statement, I guess, or the observation that when these sorts of things impact significantly on perinatal mental health, women's mental health, men's mental health, right across the board, this is obviously going to have a flow-on effect on children. And in particular, when we think about the next generation, or the generation that's currently being born into these extraordinary circumstances, we're yet to really fully understand what the impacts on mental health will be over the next 10 or 15 years. So this is where I'm from. X marks the spot. That's around Marble Bar in the Pilbara region in Western Australia. That's my homeland. So I'm a Paliku woman. That's where my grandmother was from. And just to remind us, of course, that we are all part of generational stories, and from an Indigenous perspective, knowing who you are, where you come from, where your homelands are is absolutely critical to identity. And of course, this sets up the foundations for our well-being. So as my grandmother holds my mum in the first picture, my mum then holds me and I hold my child. And so positive generational stories obviously build resilience, but when these systems are fragmented and torn apart, then of course these are going to create additional risks for our children going forward. So I think from a First Nations perspective, when we think about what happened with COVID and the concern that was raised by many of our communities, these were some of the issues that we were all concerned about. So we knew that we had a higher risk burden because of the burden of disease in our communities already. Some of our health profiles, as well as our mental health profiles, were not good. And so there was a huge amount of concern initially, and fear really, with not knowing how this was going to unfold in our communities, particularly some of our remote communities. There was a lot of concern for our elders being most at risk in the population group. And of course, elders being our knowledge keepers and our keepers of culture, the huge loss that would represent if there was a significant amount of loss across our communities. We also know that there was the potential for greater spread in some of our communities because of the way communities interact, and also because of some of the social determinants around housing and overcrowding. More recently, there's actually been some mathematical modelling that looks looks at the way a virus would spread in remote communities, and it actually is likely to have a greater potential for spread in some of our communities as compared to the city areas. We also were concerned that there would be less access to hospitals and intensive care units for some of our people who became really ill in regional and remote communities, and that overall, from previous experiences, we know that generally Indigenous peoples have poorer outcomes in relation to health and well-being when these sorts of global issues or pandemics actually occur. We also were concerned that this would also increase issues of racism and discrimination, as Louise has pointed to. And that certainly has been realised to some degree. One of the other issues that I think Louise also pointed to was what's the process of ethical decision making when we're in a global pandemic? And so some of our controls are lessened because of the need to have a population level approach. And when we had a look at some of the ethical decision making frameworks, they did not really take into account any alternative views, and certainly not an ethical decision making framework from an Indigenous or cultural perspective. And of course, we know all of the effects on mental health and well-being, and we were very concerned because of the high level of anxiety in our communities that this would also then be a double whammy. So for children, of course, there were some positives. Some kids actually enjoyed being away from school and being in the home environment. But of course, we've also then seen the potential for significant adversity and adverse experience in relation to family violence. We're probably yet to really see all of the stories emerging from children who have been in long periods of lockdown. And so it'll be really, I think, troubling to hear what some of the stories that are going to emerge are going to be like in the future. We also know that there's the impact on development, socialisation and education, and parents are significantly concerned that their children will then be left in a disadvantaged state going forward. In terms of the Indigenous population, we also have to understand that our population pyramid is already abnormal. We have a third world population pyramid in the Indigenous community where we have a lot of children, which is fantastic because they're our future. However, there are less able adults and far less older adults to actually provide care for children and provide care for adults in the community. And so if there is a greater level of loss with adults and elders, then this is going to also impact on the care environment for children. We already know that in many of our families and communities, children and young people actually shoulder a lot of the burden for care for sick relatives or for other people within the community. And of course, that will increase if we actually see these losses in our older generations. In terms of child and adolescent mental health systems, well, unfortunately, we were already in dire straits prior to the impact of COVID. And in fact, in WA, we're just in the middle of a ministerial task force looking at the whole redevelopment of infant, child and adolescent mental health services across the state. So unfortunately, across the country, but also particularly in Western Australia, there's been an ongoing lack of development and investment in clinical services and research with infants and children in particular. There's been some increase in investment in youth services, but in terms of the under 12s, very, very little investment for nearly 2 decades. And of course, very few specialised services in that area as well. There are a lot of gaps in services for children and adolescents at the moment, particularly for kids in the out-of-home care system, as well as within juvenile justice facilities. Huge gaps in services in rural and remote locations, very, very thin on the ground indeed, particularly for some of our Aboriginal and Torres Strait Islander, very remote communities, particularly in WA. We have a lot of those remote areas. And in fact, a real lack of the sort of culturally safe models of care as well. We probably have a very poorly trained and fragmented service system right from primary healthcare through to the specialised services, and a need to actually increase our workforce substantially. And of course, there's that sort of missing middle for children as well, where there might be some activity in primary care, but a real lack of that sort of first part of the continuum in terms of mental distress and issues for children, and then a real gap between that and the more tertiary systems of care. We've also seen an absolute rapid rise in demand in recent years, plus the COVID spike, which has exceeded capacity enormously. And I'm just going to go through some quick data slides because I know I'm going to run out of time. So just quickly, this is what we found currently from our Emerging Directions report that was tabled in Parliament some weeks ago now, to show the sort of rapid rise in referrals and ED attendances, which has completely outstripped the ability for our services to manage. This was pre-COVID, so we were already doing poorly in regard to this, and the COVID spike has made this much, much worse and much more at a critical point. In terms of emergency department attendances, we can see the sort of rapid rise over the past 7 years or so. In fact, this data goes back a bit further, and you can actually see this really stark increase in emergency department attendances, particularly in the adolescent group. But what we're also very concerned about is that some of the self-harm presentations are actually getting younger and also rising as well. In regard to the Aboriginal young people who are attending ED, again, a higher rate of presentation for our Indigenous populations as compared to the rest of the population group, and very concerning considering that the issue around cultural safety and mental health services is still quite significant, and the lack of a trained Aboriginal mental health workforce is still a huge concern, particularly when you get out to some of our rural and remote areas, but it's even a problem within our cities. And if we just look at referrals and activations, a continuing rapid rise in referrals across our services, both in rural and metro, with an inability to actually be able to activate at the level that's going to be required to just keep up with simple demand. And of course, we also know that not all kids will be referred to services. And in fact, in some of the consultations that we've done around referrals to services, people have actually said they've given up even trying to refer to a child and adolescent mental health system, because it's unlikely that the family will get accepted regardless of how severe they think the condition is. So in regard to COVID itself, some of the initial responses in terms of our Indigenous communities varied. Some communities were very well resourced, and others had very little in terms of coping with the pandemic. We also know that for some of our remote communities, and this was particularly problematic in Western Australia, the fly-in, fly-out workforce completely disappeared, and that was particularly problematic in our mental health services. So for some communities, suddenly their reliance on these fly-in, fly-out workforce just dropped off completely, and people were left in the care of sometimes quite lowly trained counsellors that were trying to manage very, very complex and difficult issues. Of course, the move to phone calls for wellbeing checks and to sort of internet services is great. However, for some of our remote communities, there was no internet and there was no phone coverage, and particularly for our communities that actually moved to some of the outstations, some of the ways for communication were restricted to things like radio transmitters. So although we talk about this rapid increase in sort of digital services for people, this was not equitable in terms of some of our remote communities from an Indigenous perspective. Of course, we also know that fear and anxiety rapidly escalated, and this also had a significant impact in terms of lockdowns on cultural practices, the ability to attend funerals and meet cultural obligations, but also our cultural practices that are utilised for building resilience were also restricted. If you look at the Aboriginal map that I showed you in the beginning about where my mob was from, and if we've superimposed on state borders and boundaries on those Aboriginal communities, then a lot of the boundary border closures actually impacted on several communities. And in fact, some communities were subject to, 2 states and a territory changes in how their border closures were working. So it can be very, very confusing when these things come in for communities. Although our outstations were utilised to assist in isolation, particularly for some of our elders and older people, some of the conditions were extremely poor. And in fact, June Oscar spoke about this when she returned to her community in Fitzroy, saying that the facilities in some of the outstations, was a human rights concern in regard to the capacity to live a healthy life. So in view of all of this, I'm just going to tell you about something that a group of us did under the leadership of Professor Pat Dudgeon, who's an Indigenous psychologist. I think she's our first Indigenous psychologist in Australia, through her research team at the University of Western Australia. So we got together a number of Indigenous First Nations leaders and some allies, and we set up a COVID working party. We collaborated over several weeks consulted over networks, and discussed and developed some recommendations. And that reference at the bottom of that slide actually is where all of this information will be found. And so the next few slides, I'm just going to do a very, very quick summary of what we decided was going to be absolutely necessary for the way forward. So, of course, our first recommendation was around self-determination, and self-determination being the key point in keeping our community safe. One of the things that's come out of the poor uptake with vaccinations, for example, is that most of our mobs will trust our mobs, but they're not necessarily going to trust some of the other government agencies, given our historical legacy. And so really being able to support our communities to lead the response to COVID is going to be absolutely essential. In fact, many of our Aboriginal community-controlled organisations took the lead and actually got things moving far more quickly than the government sector did in terms of keeping our communities safe at the beginning of COVID. So I think it's very evident that self-determination will actually improve the health and wellbeing outcomes for Aboriginal and Torres Strait Islander. And this is nothing new. We've talked about this for years, but I'm hoping that this COVID opportunity really provides a different way of thinking about this, because we've actually seen the really strong and positive outcomes for our people when self-determination is evident and communities have had that control and resourcing to actually meet the needs of their communities. We also need to move much more quickly now into culturally safe health and mental health services. We've always known this, but it's been very, very slow. We haven't, and I guess one of the experiences when the fly-in, fly-out workforce disappeared was we didn't have enough competent mental health workforce left within communities. And so if this was to happen again, how do we actually provide a safe mental health service on the ground when movements and other things are restricted through these sorts of pandemic experiences? And of course, one of the things that we've been pushing for a long time is the development of holistic healing, and including the use of our traditional healers and other cultural activities and cultural treatments that we've used for many, many generations now that keep our well-being and resilience intact. So the development of culturally responsive mental health services and workforce is absolutely essential, and we really can't tolerate this inequity any longer. We also have to address social and cultural determinants of health. I think people have already mentioned some of the risk factors: poor housing, overcrowding, all of these determinants that we've been talking about for a long time, including racism. These really do need to be addressed wholeheartedly now. And we also need to promote the positive factors such as cultural determinants of health and wellbeing. So those longer term strengths-based cultural, social and emotional wellbeing programs need to be prioritised. And of course, if we address cultural strengths using our ways of knowing, being and doing, is going to help to build our individual and collective identities and ultimately lead to the improved health and wellbeing, not only of our communities and families, but also of our children. Children need to actually have their identities firmly grounded in culture right from the beginning of life. Access to digital and telehealth, well, we've already really talked about this, but there's a huge inequity here. And so in regard to e-mental health, we've got to also have best practice. We've also got to have coverage for our remote communities and have holistic models of care. And then the final one is really upholding Indigenous data sovereignty. We've never really had control over our own data and that ability to access and use our data. So I think this is something that on a global scale, Indigenous peoples all around the world are also calling for. So the collective move towards Indigenous data sovereignty will facilitate that equitable participation and allow us to actually use our own data for our own good. So I think I've just got to the end of my time and managed to get through the slide deck. So I'm just going to finish with really a final statement about children. We know that children are our future. And I really hope that we don't forget this generation, especially of children who have been born into these extraordinary circumstances. We're yet to see the overall impact on this generation of kids. But I really have to say that, children's mental health and this opportunity to enhance resilience and build strong brains in the early years is absolutely essential. And I really do believe that if we have a far greater investment in these early years, we will then see the fruits of that much further down the track. That's the end of my presentation. Thank you for listening.
Thank you, Professor Milroy. Helen, you've challenged us greatly, as you should. You've given us so much to think about, and you've done it from a position of authority, knowledge, and a cultural awareness that we must acknowledge and listen to. We'll be making a number of recommendations from today, and many of yours will be contained in that. And we wish you well on your journey as you advocate not just for your own peoples, but for the Indigenous population nationally, but also for all children and families. Thank you again.
Thank you, Bruce.
Go well. I move now to introduce a wonderful colleague and friend of mine. We've done a lot of work together, and I've admired his work for many, many years now. That's Professor Matthew Sanders, who is one of the leading psychologists in this country, both academically and clinically, but in particular for his work in really, I think, taking the lead on demonstrating that helping families to manage their children actually has an enormous impact on the well-being, not just of the families, but of society in general. Matthew is at the University of Queensland, where he established and heads the Centre for Parenting and Family Support. He's got multiple academic appointments around the world in various parts and a number of universities. And he's also received recently a Queensland Greats Award from the University of Queensland, from the Queensland Government. Matthew, we look forward to your address, and thank you again for doing us the honour of presenting at this important day.
Thank you, Bruce. I'll just do a screen share, if that's okay. Thank you for the opportunity to contribute to this fantastic session this morning. At UQ, we're on Turrbal and Niagara land, and I'd like to acknowledge the traditional owners and their custodianship of the land that we're on today and that we're all meeting on. I pay my respects to elders past, present and emerging who continue cultural and spiritual connections to country. In February 2020, we held the 20th Helping Families Change Conference, an international conference in Brisbane. And we had no idea what was in store just around the corner. Within a month, there was a complete transformation of the kind of issues that we were confronted, both as a research centre and, of course, as an entire community. There were some really major disruptions in everyone's everyday life that continues to a greater or lesser extent in different parts of the country. But what was very clear very early on is that there was going to need to be a response that was focused upon the needs of parents and families in supporting their children during these very difficult times, where physical separation from our usual support networks were having significant implications for the way in which we conducted our everyday affairs. We were having to deal with educating children from home in lockdown. It has to master new technologies at work. And I think just so many people felt this tremendous sense of loss of personal control over their everyday lives, and it had expressed in different ways.
Hi, I would love to know how to handle the situation where my children are insanely competitive at the best of times. We're now spending a lot of time with each other and the competition is increasing. At what point should I intervene? And if it gets carried away, should there be punishments? And how do you think we can best minimise this? Thanks. Hi, I would like...
Sorry, I'll just go back.
I'm worried about this. What if my parent passed away from the virus? My children has never been dealing with death before, and I'm worried that they will not be able to cope with this and have had no idea how to help them as well. So what is your suggestion?
Hi, I'm a mother of a 10 and a 14-year-old, and my concerns are about the constant media and the effects that will have on my children. Hi, I'm a mother of...
And of course, children themselves had a diverse range of concerns.
My name is Atu and I'm 6 years old. And also we had our first death in our country. So I don't want anyone to bring the coronavirus into my house, and I hope my cousins or my uncles or my uncles that work at the doctors at the hospital don't get sick and die and get infected. I don't want the coronavirus to hurt my family.
Of course, the range of concerns that children have vary enormously depending on pre-existing vulnerabilities and the particular family context that they were being raised in. But what was quite clear to me very early on is that we needed a population level strategy response to deal with it, and we didn't have one. We had no funding, we had no capacity to really respond to what was clearly going to be a major set of problems that evolved. And despite that, we mobilised within about 2 weeks of the commencement of March a multi-level system of parenting support that was designed primarily through online mechanisms to support parents and children in the community. This multi-level response essentially ranged from low intensity, brief light touch supports that were primarily to do with information resources that were made accessible online, through to more intensive intervention that involved families with more severe and complex histories, particularly trauma histories. I'll just summarise some of the activities that we were involved in doing here, if I can get my screen to work. So these are examples of parenting in a pandemic online resources that were developed through PPP International and also the Parenting and Family Support Centre, that were targeting different age groups, common tips, everyday sort of advice and guidance for the general population relating to dealing with the parenting issues that they were confronting in their families. There were versions for early childhood educators, versions for parents of teenagers, versions for parents of children with a disability. This quickly turned into free, accessible online resources made available to everyone. In addition to this, we developed a workplace intervention, which was parenting during COVID-19 seminar series that Vanessa Cobham and myself prepared for our own staff at the University of Queensland. But essentially it was providing tips and advice about getting through the challenges of raising children in COVID. We also developed pretty rapidly a Parenting in a Pandemic podcast series. This was done with no funding, but bringing together local agencies and organisations, both government and non-government, and within the university sector, to help develop a 25 episode podcast series.
If you're parenting through a pandemic, then this podcast is for you.
My kids are usually great mates, but right now they're fighting like cats and dogs.
It's so hard to work from home and keep the kids entertained. It's driving me nuts.
Yeah, it's pretty scary. No one knows when it's going to end.
Should I answer every question about coronavirus? How much do kids really need to know?
I just need some help.
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 Founder of the internationally acclaimed PPP Positive Parenting Program, Professor Matthew Sanders is a world-leading parenting expert. He'll be answering your questions and providing real, actionable advice to help you steer your household through these uncharted waters.
These are truly exceptional times. Many of us as parents are not well prepared for the challenges we face right now. I'll be using everything I've learned over my 40-year career to help parents and families survive and thrive in living and working so closely together in a world of uncertainty.
Parenting.
Okay, at the same time, we worked concurrently on a 12-episode television series with Channel 7, which is accessible through our website, stripped of any advertising, and essentially cherry-picked the main topics out of the podcast series. In addition to that, we worked on a podcast for professionals called Families Under Pressure through the Life Course Centre, which is funded by the ARC. And that was a six-episode initial Families Under Pressure series. And we've just started a second series in the last couple of weeks. The other thing that became very obvious is that we needed to look at the existing online programs that had been developed as evidence-based tools in the P multi-level system of online support for families. This included P Online, Teen P Online, and more recently, Fearless P Online. It was quite clear that there was going to be some significant changes in demand for telehealth and online programming. And so we developed a COVID-specific module that front-ended each of these online programs. Now, one of the important things to recognise is over the same time period, we were coming to the tail end of a number of randomised trials looking at the effects of delivering the P system as an online 8-module intervention program. And I'll come to what we found out recently. But of course, the onset of COVID led to a very substantial increase globally in accessing online codes over the 2 months prior to, and then 2 years prior to the onset of COVID, then 2 years and subsequent to it. This is the level of increase that's taken place in growth of registrations online. We've just published a randomised trial result in Journal of Child Psychology and Psychiatry, which is known as a non-inferiority trial. And this was the first demonstration of a test that the delivery of an online variant of intensive individually delivered parenting programs focusing on children with early onset conduct problems between the ages of 3 and 7. When they were randomized, this is 334 parents were randomized to either the online program with absolutely minimal professional support other than technical support to get going, and compared that to in-person delivery on multiple indices of child outcomes at 12 months follow-up. There was comparable outcomes for the online versus the in-person delivered program. This is based on parent report data, independent observation of parent-child interaction, and teacher report data. And the online program was associated with medium effect sizes in terms of independently observed behaviour, but large effect sizes for parent reports of improvements in child behaviour problems. And of course, significant reductions in daily hassles and adverse quality of family life. We then have just published a study that integrates 7 different evaluations of the online program with over 1,000 families participating. And effectively, what we've been able to demonstrate is a positive impact on parenting practices, parenting confidence, and child behaviour problems. Module completion is a significant predictor of improved outcomes. But the pre-intervention levels of the difficulties, basically we're getting stronger effects for those families with more severe problems. Socio-demographic variables, income, educational level were not significant predictors of program outcomes or program completion. And the best predictors of program completion were parental self-efficacy prior to entering the program. In other words, parents with more self-regulatory capability had a better chance to be able to do it independently of having some additional support. Their experience with the internet was also important, and the more intensive variants of the online program were better than the briefer variants. And of course, this is with children with more severe in this sample behavioural and emotional difficulties. But the important finding fundamentally is that those parents who entered the program with high levels of depression, did just as well as non-depressed parents if they received additional professional support. And a trial conducted in Western Australia showed that that support involved up to 4, but no more than 4 phone calls as the parent was going through the program. In addition to that, in dealing with anxiety, we've just recently released Fearless PPP, which is a 6-module online program that builds on Vanessa Cobham's work around preparing parents to be able to manage children's anxiety. And this has become, both of these programs are freely available online in Victoria and Western Australia. These build on 2 randomized trials that have shown significant intervention effects for this Fearless intervention, which is a parent-only intervention that's producing effects on anxiety disorders in primary school age children that are comparable to the best CBT-based interventions for childhood anxiety, which is really encouraging. And finally, the most intense level of intervention, we're in the midst of a feasibility trial of this new intervention called Family Life Skills. It's being trialled in Sydney with colleagues in Sydney Central Health Authority. And essentially, it's a variant of the program for parents who themselves have pre-existing difficulties based on their family of origin experiences and trauma. It's a modularized 10-session program that immediately transitioned from group-based delivery to Zoom-based group delivery, and this feasibility trial is still in progress. But encouragingly, the thing that has been very interesting with this is that even families with high levels of pre-existing difficulties, there was a high degree of interest and engagement in participating in Zoom-based delivery of the program. And of course, this is influenced by whether or not the family has access to a reasonable internet connection. But for those who didn't, they were able to come into the clinic to access the program online through the clinic. So this is a program that is just in feasibility trial stage. We'll move then on to a randomized trial, but it's reflective of the fact that during COVID, that because of differences in the levels of parenting support that people require, we can't have a one-size-fits-all. And a true multi-level population-based intervention, of course, has to recognise that one of the effects of this was how professional training is provided. PPP International had to rapidly transition to Zoom-based training, and we've recently submitted a paper that compared the effects of in-person training with 57,000 practitioners from around the world with Zoom-based training of the same 3 to 5 day training programs. And there's been no significant difference in practitioner outcomes in terms of self-efficacy to do with their use of the program, satisfaction with training, and overall, there's been high levels of satisfaction. We are now moving into the need to develop AI-assisted professional training in providing evidence-based parenting support for, we've trained now over 100,000 practitioners who are drawn from 57 countries around the world in 22 languages where the program is being delivered. The other thing that we transitioned rapidly to was the development of masterclass support. And I'll just give you an example of the kind of questions that we are receiving from practitioners around the world.
Hello from New York City. My name is Barbara DeGangi from University Settlement's Families Thriving program. My team and I were wondering, what are your best tips and practices for moving a practice session to a virtual environment? How can we ensure that parents have mastery and can apply the skills and tools they've learned?
Hi, Professor Sanders. My name is Stephanie Nunez. I'm a behavioral health clinician with the Orange County Healthcare Agency in Orange County, California. My question for you is, what are your suggestions for how to adapt PPP online with parents of special needs children? Thank you.
So there are literally hundreds of questions that have been coming through. Where we're moving now is to link evidence-based parenting support to the UN Sustainable Development Goals. We're working on a concept brief and a program called Our Place, Our Futures. And this is combining with a technology-based platform, school intervention, family intervention, and community to focus on ecologically sustainable living for families. My key takeout essentially is that evidence-based parenting support must be a crucial component of any comprehensive mental health strategy in response to COVID. And here's where you can get further information about what I've been speaking about today. So thank you very much for your attention, and over to you, Bruce.
Well, thank you, Professor Sanders. Matt, you've highlighted a couple of issues. Firstly, you've brought in those little snippets of video the lived experience of families, mothers, presumably fathers, and most importantly, the voice of a child. You've also brought the lived experience of clinicians working in this COVID experience, again with some statements from clinicians about what they need. But the most important thing, of course, that in fact you've highlighted in everything that you've presented is that things work, but we need to know they do, and they need to be evidence-based. And there's so much information out there on the internet about how to raise children, what to do and what not to do, and much of it is rubbish. But you are emphasising, and we must take this as a take-home message, that any interventions we introduce, any public health changes, anything we introduce in our health or social welfare services must be backed by evidence. Otherwise, we're wasting our time at most, or even worse, maybe making things worse. Thank you very much for your presentation. I acknowledge your enormous contribution, not just to Australian child and family health and wellbeing, but internationally. It's now time to have a break until 12:50 Eastern Summer Time, when Dr. Alberto Veloso will come on stream to introduce our next speaker. Thank you for your attendance again. Stay with us on this most important day, and enjoy your break. Have some good refreshments, a cup of tea, glass of water, something to eat, and we'll see you soon.